Hey, good morning, everybody. My name is Tim Bentley, and I'm the Advertising and Marketing Manager for Tucson Medical Center. And if you are here for the Keeping Kids Safe with Diabetes at School conference, you are in the right place. We wanted to welcome you today and thank you for allowing us to, to meet you in a new and different way. 2020 and 2021 have made us and encouraged us to get information to you, our school nurses, and our educators in unique ways. And so by being here live today on YouTube, we can reach a big audience, answer your questions, connect with you while still keeping socially distanced. And this is truly socially distanced today. I wanted to give you a couple of house cleaning items before I turn the show over to our friends at the TMCOne Pediatric Endocrinology Clinic. You can ask questions today in the chat function on the YouTube page. When you do that, you can type it in. We have people in the back that will answer your questions directly. If it's appropriate, we will forward it to our presenter and answer it in real time if that makes sense. If you are with us all day, we will have 10 or 15 minutes at the end of this conference to answer specific questions you may have. Pay attention to the words and the graphics that I'll put up. It'll have our email that you can reach out to us and any phone numbers that we may pass along. So those are some house cleaning items. Thank you. If there's a stumble or two, we'll make sure that we get right back to where we are and our starting point. So thank you again for letting us meet you this way. I wanted to introduce Dr. Chetan Patel, who is going to start us off today and get us going on this conference. Dr. Patel, I'll take myself out and let you guys get on with the show. See you soon.
Thank you, Tim. Welcome, everybody. Appreciate you guys taking out your time to learn with us and to get educated and help us take care of these kids with diabetes. I just wanted to go through a few things and kind of introduce myself. I've been here at the Tucson Medical Center for about 4 years now. We started the program for pediatric endocrinology. Obviously, there was a need we saw to start the education process and make sure that the community was connected with us so that we could really help take care of the children and make sure that there was good communication between the healthcare providers and the school nurses and the school healthcare personnel, everyone who's extended. So this is our 3rd year. It's been really great. The support, the turnout has been wonderful, and we appreciate it. I just want to kind of go through the rest of our team. So it's myself, and then there's Dr. Preeti Gupta Patel, who's one of our other physicians who's here with me, and then also Dr. Rashida Tawari. The 3 of us have been very lucky to work with our team, and the team of educators has been wonderful. So as many of you guys have talked to the team back here, especially when there's problem children coming in or you guys need help or a new diabetes patient has come in, then it's been very, very helpful to have them. So I will just introduce each of them briefly. So Apame Bashar is our dietitian who's been here the longest with us, and I tell the story all the time about how I thought she was too serious when she interviewed to work with children, but she's not. And if you ask her, she'll sing and dance for you if you want her to. Nancy Kuzman is our nurse educator, and she's also been here a few years now, and she's out of Chicago and is a huge Blackhawks fan. Callie Sidorowitz is our dietitian who's been here also 2 to 3 years now, and she is a Wildcat fan, but the wrong Wildcat. She's a K-State fan. Shannon Gorel is our dietitian who's also here with us. She'll be in the next presentation. She has 2 children, and I don't know anything else about her other than she has 2 children. And so and Juliet Westbrook is also our nurse educator, and she's out of Colorado, but she's been in Arizona for quite some time, and it's been great to have her. She also has 2 kids and lives in Vail, and we have lots of conversations about the kids as well. Anju Patel is our new dietitian who's been here with us for a little while, and she's been great to work with. Cassandra Verdugo I've known for a long time, and she worked with me over at the Angel Clinic when I was at the University of Arizona. And she is a big Wildcats fan. And then we have a new one, Angel, who is our pharmacy, or the pharmacist who's also joined us on our staff to help. I just wanted to go through a couple of the other things that we were trying to get to accomplish with this conference. One is that, it's our partnership. So we as physicians, we work as a team with our educators to help provide care for the kids. Without them, our clinic, the functioning wouldn't be nearly as good as what we have right now. So I just, I wanted to thank them. And then I also wanted to thank the schools and the educators, because without the schools and educators, we can't really take care of kids. They spend most of their time at school or at home, not with us. We see the kids, a fraction of their life cycle. And so without reaching out and having partners, it doesn't work. And so it's really great that everyone takes out their time to learn. I do want to say a couple of things that we've accomplished at the clinic here. So we are now an American Diabetes Association recognized clinic for diabetes self-management education. So it's a national recognition, and our educator Juliet has been leading that, and our educators have all been contributing to making sure we meet those requirements. The other couple of things I want to let you know about our clinic is that we're TrialNet approved, and so we are a TrialNet site. So TrialNet is a study designed for relatives, first and second degree relatives of patients with type 1 diabetes. And what we do is we draw their labs to see if they have any antibodies that are positive for type 1. If they are, then TrialNet is a very large umbrella organization that goes across the country and in a few other countries. And they will help coordinate some of the early onset studies that we have. One is trying to prevent the diabetes onset, and the second one is trying to extend the honeymoon period. So once they're diagnosed and you get to the honeymoon period, some of the studies have been aimed at fixing that. Let's see. We have gotten a grant from the foundation, the TMC Foundation, to do this conference. So we're very appreciative of all the foundation people. And if you know any donors, send them to the foundation, because we could certainly use continued support. The other big part of it is we're going to be doing a fun day for the patients in the clinic and trying to get them connected to each other. So on November 6th. So if you have any TMC1 patients who want to come out to Himmel Park and if they register, it would be absolutely wonderful. All right, so I think, hopefully we'll all continue to do good things, and then we'll help with you guys getting educated and be your partners in the community. I don't have anything else, so I really wanted to thank Tim and appreciate his time and his effort with this conference. He's been absolutely wonderful in our communications department. We will transition over to Tim, and then I will get Juliet started on her presentation. Yeah, it's perfect. Now you're ready. See?
Yep. And then Juliet Westbrook. I'm one of the diabetes educators and registered nurse here at TMCOne Pediatric Endocrinology. Thank you for attending the conference today. The school nurses and health aides, you all do a very, very important job, and thank you for all of your effort on behalf of the children in school as with and without diabetes. You guys do an amazing job, so thank you very much. So today I'm going to present the Keeping Kids with Diabetes Safe at School conference. And what we will do, if I can get my PowerPoint to advance, is we're going to talk about the basic pathophysiology of diabetes. Here are our objectives. We're going to describe the basic physiology of diabetes, the differences between type 1 and type 2 diabetes, understanding the treatment plans, the importance of diet and exercise, and healthy coping for children with diabetes. So what is diabetes? We all know that the body needs energy to survive and to function and do all of the things that we do in life. And that energy is created in the form of carbohydrates that we get from our diet, as well as stored forms of energy in our body. The pancreas produces insulin, which is responsible for moving blood glucose or sugar into the cells to be converted into energy. Think of insulin as the key that unlocks the cell door to let the blood glucose get inside the cell where it needs to go. The pancreas releases insulin throughout the day whenever it is needed in large amounts to regulate that blood sugar, either after a meal or other times during the day. When the body is not able to keep the blood sugar within a target range, that person is then diagnosed with diabetes. I'd also like to mention, as a side note, if you do have comments or questions during the presentation, please put that in the chat box and we will make sure that we answer those questions either live or later on via email if you're watching the conference at a later time. So how do these kids present? We will see several things frequently in these children with diabetes. We will see increased urination or polyuria. We will see increased thirst. These children are just very, very thirsty. They're requesting water a lot. So polydipsia. Bedwetting. Bedwetting means urination at night in an otherwise potty trained or toilet trained child. Weight loss, fatigue is also common. Nausea and vomiting, and heavy breathing. The heavy breathing or small breathing is not something that you're likely to see at school, but you might see that. So if you notice that the child presents with that heavy breathing or nausea, vomiting, and these other signs, that is an indicator that they might have diabetes, or if they have diabetes, that their blood sugars are very high. So what happens in the body with diabetes? We know that our body needs energy and insulin. So when our body doesn't produce enough insulin, several things happen. We have protein breakdown, which results ultimately in muscle wasting. We have fat breakdown, which results in keto acids. We have high blood sugar because that insulin is not allowing that blood glucose to get into the cell, and the glucose builds up into the bloodstream. Our liver makes more glucose, and ultimately we'll see increased urine production with glucose in the urine. And then because of that increased thirst and increased urination, we ultimately see signs of dehydration. In type 1 diabetes, it is an autoimmune attack of the beta cells of the pancreas. What that does is it produces an insufficient production of insulin, and that leads to hyperglycemia or increased blood glucose. In type 1 diabetes, in the image at the top, you can see what normally occurs in the body, where insulin lets the glucose into the cell. Glucose then is converted into energy. But in the bottom, you can see that cell is locked, that the insulin is not able to unlock it to let the glucose into the cell. And so blood glucose builds up into the bloodstream. Type 2 diabetes is a resistance to the action of insulin. It initially presents with hyperinsulinemia, or too much insulin in the body, eventually leading to insulin deficiency and hyperglycemia, which is high blood sugar. In this image, you can see the action of insulin resistance. So the body is still making insulin. Insulin tries to do its job by letting the glucose into the cell, but some cells cannot get enough glucose for energy and builds up into the bloodstream. How do we treat diabetes? So type 1, you will see that it is always treated with insulin. The goal is to replace insulin that is no longer produced in the body. Type 2 is treated with diet, exercise, oral medications, injectable medications, or insulin. And our goal is to help the body better utilize the insulin to become less resistant. You'll also see children with insulin pumps and continuous glucose monitors at school. Continuous glucose monitors, or CGMs, are used to treat both type 1 and type 2 diabetes. Callie is going to review insulin pump and CGMs later with you in more detail. Insulin pumps take the place of multiple daily injections. So initially, as the school nurse, you might see a child who is on multiple daily injections, either using a syringe and vial of insulin or a insulin pen. And then CGMs take the place of finger stick blood glucose monitoring. And again, Callie's going to go over those in greater detail with you later today. Medications that are used to treat insulin or diabetes, type 1 or type 2, long-acting basal insulin, such as Lantus, Levemir, Basaglar, Tresiba, Toujeo, those are not generally given at school. However, you may encounter them because sometimes parents, due to scheduling in the evenings, might feel that giving that basal insulin in the morning or while they're at school is the best option for that child. So those are given once per day. Short-acting insulin is given for meal times or for blood sugar correction doses. Humalog, Novolog, Apidra are the most common that you will see. Again, they all come in either a insulin pen, or you might encounter them with an insulin pen or syringe and vial. Ultra rapid acting is just another medication. It has a quicker onset of action, and you might see that in FIAS. Oral medications are most commonly used for type 2 diabetes, and metformin is the most common medication that you will see. GLP-1 receptor agonists are utilized for type 2 diabetes. Again, these are not usually given at home, but you may encounter them if the child's family or the physician wants it to be given at school. But the most common are Victoza or Bydureon. Those medications delay stomach emptying, making children feel more full and satisfied. They increase insulin release and they decrease blood sugar release from the liver. Rescue medications that children have are Glucagon, Gvoke, Baqsimi, or Zegalogue is the newest one. And you should make sure that if the child is on insulin, that they also bring those medications as well. Blood glucose monitoring should occur 4 to 10 times per day. That is a finger stick blood glucose measurement. They will need to carry their supplies or have their supplies in the school nurse office with them at all times. Lancets, test strips, a glucometer, alcohol wipes, and a lancing device. Continuous glucose monitors, the most common are Dexcom, Freestyle, or the Guardian sensor. Those provide blood glucose readings every 1 to 5 minutes, either via an insulin pump or a cell phone or a receiver. The sensor is placed under the skin and is usually worn for 7 to 14 days. All right, so I liked this slide that everyone get up and move. It's always good to move and it's always good to maintain physical activity for all of us, but especially children with diabetes. They should not be precluded from participating in sports or PE. Exercise benefits, stress relief, health maintenance. It's good for our heart, it's good for our lungs, it's good for our brains. Weight management and muscle strength, improving cholesterol and lipid levels. In the body, it makes the body more sensitive to insulin, and it really does help with blood glucose management and lowering. Nancy is going to go over how to monitor and treat for low blood glucose levels and high blood glucose levels later today. Even though exercise is very important, there are some precautions that need to be taken into account for a child with diabetes at school. The American Diabetes Association recommends glucose before exercise be in the range of 90 to 250 via a finger stick or a CGM reading. Vigorous exercise should be started slowly and gradually build in level of intensity. Teachers, coaches, anyone that's going to be with that child either during PE or during the sporting event should be familiar with the signs and symptoms of low blood glucose and how to treat that. And they should also have their rescue medications with them and their glucometer or CGM, all of their supplies that they would normally carry with them. Students should not exercise if symptoms of a low blood glucose are present. They should also not be left alone. Hypoglycemia treatment should be available at all times. So that should be that 15 grams of rapid acting glucose source, glucose tabs, some children have Skittles or 4 ounces of juice. That should be available to them as well as their rescue medication. If the blood glucose before exercise is greater than 250, it is recommended that the child check or you assist the child to check the urine for ketones. And if ketones are moderate to large, the student should not participate in an exercise activity, sports, PE, those types of things. Make sure that you contact the student's parent if after school activities are going to go beyond the end of the school day. For example, for a dinner time, like maybe they're on a long field trip or they have a sporting event or another school function. So if they are going to be there beyond the end of the school day, that you coordinate with that parent on how the insulin for dinner time will be given and how that blood sugar is going to be for those events. Healthy coping for children with diabetes is very, very important. Any child with a chronic disease certainly goes through periods where they have a hard time and they might have increased stress. So healthy ways to manage stress is very helpful for children with diabetes. Having a supportive family, friends, support groups, a counselor or a therapist can be utilized. We have a social worker here on staff who, also encourages, school nurses or health aides to reach out to her. You can contact our clinic if you ever feel that you have a kid who is struggling, and she'd be happy to talk with you and provide resources for them. Being active, again, being active helps with our mental health as well as our physical health. Being positive and celebrating that success. So maybe you have a child who was really struggling with giving an insulin injection, if their peers were present or if, they were afraid to go to the nurse's office because they didn't want anyone to know about their diabetes. And you're working with them to overcome that, and suddenly they do. Celebrating that with them can go a long way to helping them cope. Setting realistic goals here at the clinic. Every time the child comes in to see us for an office visit, we review and set goals related to their diabetes. And we want those goals to be realistic and attainable for them. Being open with concerns and feelings for the child is very important. Again, if you notice that there's a child who's really struggling, reach out to either your school counselor or to us, or both would be wonderful. And again, seeking help when needed is always beneficial. So that is the end of my presentation. Again, if you have questions or comments that you'd like to share, please put those in the bottom in the chat box and we will address those later or as we go through the presentation today. Thank you all for attending. Have a great weekend.
Good morning, everyone. I'm Shannon. I'm one of the registered dietitian nutritionists in the clinic, and I'm also a certified diabetes care and education specialist. So I've worked in nutrition in the hospital setting for over 10 years, and then the past 3 years, I've been working with pediatric diabetes and teaching our families, especially on the weekends from when they're initially diagnosed and getting them ready for home. So today I'm going to focus in on the nutrition aspect of managing pediatric diabetes and kind of share what we teach our families and the tools that we use to help them manage the nutrition at home. So our objectives for today are to just describe general healthy eating principles for our children with diabetes, and help you use a variety of resources to be able to help our children count their carbohydrates and dose their insulin appropriately, and understand how different foods and nutrients that our children eating can affect their blood sugars in different ways. One of our main ideas is that there's no one size fits all recommendation. We just really promote healthy eating for children, which shouldn't be different. Healthy eating for a child with diabetes is not different than healthy eating for a child without diabetes. They're the same principles. We focus a lot on carbohydrate counting and dosing the insulin for those carbohydrates, but it's more than just counting carbohydrates and dosing insulin. There's still other topics that we go over and food choices that we encourage, whether they have carbs or no carbs. And I think one of the most important things I've had as far as feedback from families is that they say, you know, people will tell them as long as they count their carbs, that's all that matters. And that can be misleading for them because it's not just about counting the carbs, it's the whole eating pattern and what are the foods on our plate and what type of nutrients do they have. With that being said, we do know that the amount of carbohydrates and how much insulin is on board have the biggest effect on the blood sugars, especially the post-meal blood sugars. So it is important that we're accounting for all of those carbohydrates when we're dosing our insulin. So general healthy eating practices that we try to promote with our children are fruits and vegetables, especially, you know, fresh fruits and vegetables, get all of those nutrients from the skins and the fibers and the flesh. Whole grains, our whole wheat products, our lean proteins like our chicken, our turkey, our fish, and lean beef, low-fat dairy products or dairy substitutes if they have a hard time tolerating dairy products, and healthy snacks. Healthy snacks is huge, especially with the pandemic and how our children have been home, kind of not being as active and having free range to snacking during the day. So healthy snacks is a huge part of their diabetes management. We want to share positive messages about food. There are no forbidden foods. We can incorporate every food item, whether you're at a birthday party or a family celebration, to just our regular breakfast, lunch, dinner, everyday meals. But we don't want our children to be afraid to eat or have negative messaging towards food. Eating is on a spectrum. You're always going to have foods that you're going to eat more often that are healthier for you versus foods that you're going to limit during the day. So just knowing that we're not forbidding them from eating any certain item. Drinks are also a very important part of their day and their diabetes management. Water is so important. Staying hydrated helps with blood sugar management. So water is going to be one of our best beverage choices, and then low-fat milk or dairy substitutes as well. Trying to limit sugar-sweetened beverages. They're great for treating low blood sugars, but when we're trying to manage our blood sugars during the day, it's best if we can limit our sugar-sweetened items. You can use a sugar-free option in place of a regular sugar-sweetened item. So a diet soda can be used in place of a regular soda as far as blood sugar management, but we don't want to share a message that it would take the place of water. So always encouraging water and hydration will be our best choice. This is kind of a simple meal planning tool that you can use. I know a lot of our health aides and nurses do counseling with their children when they're with them, and I think that's so wonderful because they see you every day. They trust you. You're a great resource for information, and so giving them these tools to help them plan meals can help them be successful with their diabetes management. And so the My Plate option is just an easy graphic to use to help them plan meals. You know, we want to incorporate fruits and non-starchy vegetables and our whole grains and our protein and our milk or yogurt on the side to help them plan a healthy, balanced meal. So if you're ever doing education with them during their meals, if you go for the simple visual and help them understand what a balanced meal is, that can help them be successful. More information about carbohydrates. So a carb is not simply just a carb. All carbs are not created equal. You have simple carbohydrates, which are easily and quickly broken down to be used for energy. And they're naturally found in foods like fruits and milk, but they're also found in larger amounts in like things like candy and syrups and soda, like our more processed dessert foods. And then we have our complex carbohydrates, which are like our fibers and starches. And those food items with complex carbohydrates are digested slower. And they're found in things like peas and beans and our whole grains and vegetables. And they're also usually good sources of vitamins and minerals and fiber. So when we're meal planning and snack planning, we want our children to at some point be able to choose like the biggest bang for your buck. How am I going to spend my money for my nutrients on my meal? I'm going to choose the most nutrient dense items like our fruits and our vegetables and our whole grains, because that's where I'm going to get the most payback. I'm going to get the most nutrition from those items. When it comes to carbohydrate counting, this is definitely a needed skill for the way that we dose insulin. When they're using multiple daily injections, they need to know, and you need to know, the insulin to carbohydrate ratio, which is basically a unit of rapid-acting insulin, like your Novolog or Humalog, for every X amount of carbs. So depending upon how old they are and how much they're eating, they may be on, if it's an older child, they may take a unit of Novolog for every 5 grams of carbohydrates, or a younger child may take a unit for every 30 grams of carbohydrates. But that's information that you should know and should be included in the school orders as an easy reference. Depending upon their blood sugar trends throughout the day, the ratio can change. They can have different ratios for breakfast and lunch and dinner, or morning versus afternoon. And again, that information should be within your school orders so that you have that easy reference. If they're on an insulin pump, their ratios are already programmed in their bolus settings. Far and few between, we'll have some children that are on set dosing, which just means they get a set amount of rapid-acting insulin for their meal or snack. We have families from all walks of life and all different education levels, and sometimes using the set dosing is more realistic for them. It's more doable for them. So on occasion, you may have a child who just takes X amount of units for a certain meal or snack. And then if you have a child who's following that type of insulin plan, eating a consistent amount of carbs at meals and snacks will help match that dosing and manage those blood sugars more efficiently. So strategies to know the carb counts for the food items. Always check the serving size. It's quite variable between what you're eating, from goldfish to if you're drinking something. And we must know the serving size that our child is eating and then be able to adjust the carb counts for that amount. So check the serving size and then the total carbohydrates. That's how we dose our insulin, based on the total carbohydrates. The total carb number will include all of like the sugars and starches and fibers. So that will be our go-to number when we're dosing our insulin. And then also be mindful, if a child is eating a whole container of something, there can be 2 to 3 servings in a whole container. So in that case, we'll need to multiply the servings per container by the total carbohydrates. And I always tell my families, make it simple. For goldfish, don't eat 16 and a half goldfish. Try to portion it out so that it's an easy number to divide by. Are we eating a fourth of the portion size, or half, or whole? Make it simple and doable. Other resources that you can use outside of the nutrition facts label, the Calorie King app and the accompanying book are probably my favorite resources. The app especially, it's free for both Apple and Android phones. The Calorie King book is, anywhere around $10. You can order online if you want to have that physical resource with you. But I love Calorie King. It's a trusted resource. It will have an average across all brands section if you don't know the exact brand of the food, to specific brands and fast food, any chain restaurants. So we teach to that, especially for our new onset children. Then you have MyFitnessPal. They have the barcode scanner ability, which is nice, but a caution with MyFitnessPal is that users can update the database. So we want to make sure that the information we're using is correct, whereas Calorie King users do not adjust the data. And one of the apps that I've been teaching to more often is called the Figwe app. Again, it's a free app for both iPhone and Android. And it provides a visual representation of food that you're eating. So if you were to go out to a restaurant and you have fries on your plate, you can look up fries in Figwe and adjust the serving size. Just toggle a sidebar to see how those fries look on the plate and compare that to the app. So for your visual learners and counters, that the Figwe app is really helpful. So I just encourage you, if you haven't already, download these apps, play with them, see how they might help you during the school day. And then our third kind of way to find carbs in food, so you have your nutrition facts label, you have your apps or your Calorie King books. The last but not least would be your serving size estimation, would just tell you, this particular food choice, like a slice of bread or a half a cup of juice, generally has 15 grams of carbs. So if we have nothing else, we can at least refer to the serving size estimation guide. And so maybe an idea for you would be to just download one of those guides, print it off, have it hanging in the office so that if you have no other references to use, you can look at the serving size estimation guide to help the children find the carb counts of their meals or snacks. As far as timing of insulin, it works best if you give it right before the meal or snack. So we bolus right before meals. If you are working with preschool or younger age children, they are oftentimes unpredictable eaters. You're not sure, they have big eyes, and then all of a sudden they only eat a quarter of what they thought they were going to eat. A strategy for managing that, and again, this should be written out for you in your school orders, is to check the blood sugar, allow the child to eat for up to 30 minutes, and then give the bolus after you've seen what they've eaten after 30 minutes. So that can be a way of handling our unpredictable toddler and preschool age children. I'm just going to show you kind of a little bit more advanced information, just something, kind of think of it as fun facts just to keep in mind, especially this graph. What you can see is that the carbohydrates have the biggest effect on the blood sugar. And we see that pretty immediately. And that's why dosing insulin for carbohydrates works so well. We have our rapid acting insulin working on these rapidly digesting carbohydrates. But we also have other nutrients that can affect the way our blood sugar responds, like protein and fat. Fat and fiber leaves the stomach last. And so typically meals that have a lot of fat content plus the carbs will be digested slowly, and we might see the blood sugars stay higher for a longer period of time. And so some children may have different ratios depending on the different meals that they eat. Like if they have pasta with a creamy Alfredo sauce, they might use a different way to dose their insulin to help manage how their blood sugar responds to that high carb and high fat meal. So different ways that children might handle those more mixed nutrient meals is they might give a little bit more insulin. They might split the dose, give some at the beginning of the meal and the remaining a few hours later. Or if they are an insulin pump user, they might use the features like square wave or extended bolus or dual wave to accomplish that same thing, giving insulin over an extended period of time to address that hyperglycemia that happens more than just a couple hours after the meal. Another option would be to increase the basal rate for a few hours after the meal. Again, just different advanced features to be aware of that some children may use depending on what they're eating. Another kind of advanced method that you might come across is adjusting carb counts for fiber and sugar alcohols. These are partially digested nutrients. So if a food item has more than 5 grams of fiber, you might find that a family will subtract half of the amount of fiber from their total carb count and dose their insulin based on that. Same for sugar alcohols. They're not completely digested, so if a food item has more than 5 grams of sugar alcohols, you can subtract half of those grams of sugar alcohols from your total carb count. So again, this should be something that is outlined for you in your physician orders, not something that I think anybody would expect you to do on your own. This is just more information that if you have a family who says that they're doing this, you understand where it's coming from. So in summary, a carb is not just a carb. We take in consideration all of the nutrients in the meal and make adjustments after we see patterns. So diabetes is all about pattern management, what happens when we eat these foods over time, and then kind of playing with our insulin and our dosing strategies to help us manage our blood sugars. But it's definitely a trial and error process, not something we would expect you to do as school staff members, but to know that there are some other more complicated methods towards carb counting and managing blood sugars with meals. And so with that, that's the end of our presentation. And thank you so much for being here today with us. And we look forward to addressing your questions.
Hi, everybody. My name is Alpameh Bashar, and I am a registered dietitian and diabetes specialist. And I've been a dietitian for over 20 years. And I've been here at the clinic with Dr. Patel from the start. And thank you, everyone, so much for joining us. We really rely on all of you in taking care of all of our students. So my topic today is insulin dosing. And I will review the calculations with you. From our previous experience, what I have seen is that perhaps some will get the calculations quicker than others, but just bear with me. And when you get our slides through email later, you will be able to actually have those slides to rely on. And here we go. So the objectives for today are to discuss with you explain to you the components of a school order, what pertains to the school nurse, to the school health aide, to the school health assistant, or the administrative staff who are helping the student, and the calculations that are involved in dosing that insulin for the child. Hence, we will discuss the insulin to carbohydrate ratio. You will see this as the acronym ICR or IC. Then we have the insulin sensitivity factor. The acronym would be ISF. This is the correction. So when you see certain children on pumps, you will see sensitivity factor written on the pump. You will see the correction factor in various documents. Also, we will calculate the total injection dose that is needed before the meal or the snack at school. Additionally, we'll discuss the desired blood sugar levels, the ranges that we prefer for the children, and utilizing insulin vial versus insulin pen. And a topic, Sharp's disposal, that I don't need to really preach to the choir. You guys are pros at this, but it's my main concern really is the children and the practices that we hear about that they do. One source that I would like to share with you, it's an excellent resource for you, is the American Diabetes Association. Phone number is 1-800-DIABETES. And the website is www.diabetes.org/safe@school. When you go to this website, you will actually have access to a lot of phenomenal information that is so well explained, it's simple to follow, and it's very useful for all of you, as it has been for us. School order, as my friends have alluded to, you will get those from your students brought to the school to you. The parents will bring it to you. We might fax them to you, all of that. So you will have access to the school order for that student, and it will specify in it the diabetes management of that child during the school hours. And it will have the insulin to carbohydrate ratio for you. The ISF, again, is the insulin sensitivity factor or the correction factor, as well as the blood glucose target for that child. In the school order, you will also see how to treat the highs, how to treat the lows. And those are all spelled out in our school orders for you, as well as the signs and symptoms of low blood sugar, hypoglycemia, and hyperglycemia, high blood sugar. One side note, my friend who's going to come and speak with you next will speak about details of how to treat the hypoglycemia and how to treat the hyperglycemia. In the school order, it will share with you the document when to check the blood glucose for the child, or if the child has the sensor glucose, that you may very well rely on that sensor glucose. Therefore, you do not need to utilize a blood glucose meter unless you are in doubt of the data that you are seeing from the CGM or continuous glucose monitor. And you will always have us as your backup. You contact the clinic if you need any help with the explanation of that school order, or if something is not clear to you, or you just have further questions. So we are always here for you. Our number is 520-324-1010. The school order is just a guide. Remember that. It's just a guide. But a lot of times you will encounter situations where we really require critical thinking, and you say, okay, this is a complicated situation. What do I do? Depending on how the child is feeling, depending on the complexity of the situation, know that you can always contact us immediately, and we're always here to help you. Possible resources for you, of course, the clinic is number one. The websites for the American Diabetes Association, which is the ADA, or JDRF, Juvenile Diabetes Research Foundation. The parents are always your guide. If you ever have a question that you feel it's more complex and the parent or the caregiver must be involved in the conversation, do call them first to ask your questions. You have experienced a lot from the previous students that you might have had with diabetes. So your past experience is your great resource, of course. And then the pump and continuous glucose monitor websites are always a resource for you as well. The school orders are always updated by the clinic. Anytime that we see the child or the parents call us and they say, you know, our child's sugar has been high or low, we make changes, we are cognizant of the fact that we must provide the school with an updated school order. So you always will have that updated school order coming your way. And we make the modifications, and it all depends on what the student's situation is. For example, you might call the clinic and say, our student's glucose is always elevated. And what we will do, we will call the parent. We will discuss it with the parent. We will look at the report of their glucose if they are on a CGM or a pump, and we will make changes accordingly and send you an updated school order. This is just a screenshot of the front page of the school order that we have. And what I have brought to your attention in the box is the area where you will see under number 2, insulin injection or pump bolus. You will see that the type of insulin that the child is using is always the rapid acting insulin. And the injection for the child before the meal, you will see where the 3 stars are for the grams of carbohydrates. We will fill that in for you, how many grams of carbs for 1 unit of Humalog or Novolog or whatever the rapid acting insulin is that the child is using, as well as the correction bolus or the ISF. It'll be 1 unit of that rapid acting insulin for a certain factor, let's say 30 points above. Blood glucose 120 milligram over deciliter is this particular case's target level that we have specified in the order for you. So that information, that box, the red box information, will vary throughout the year when the student is with you. So you will see those changes and you refer to the updated school order in the care of that child. Let's talk about the insulin to carb ratio, or IC. So we correct the accounting, is the correct accounting of the grams of carbohydrate for the student that they're going to be consuming for their snack or their meal with you. Some students eat breakfast and lunch at school. Some students have just their lunch at school. So the ICR, or insulin to carb ratio, of course, is provided by the physician depending on how their blood glucose has been post-meal or post-snack. So the caregiver, the school nurse, school health aide or assistant we'll add all the carbohydrates, divide the total of carbohydrates by that ratio that you will see for the insulin to carb. Now, sometimes parents do add up all the carbohydrates and include that information in the school lunch for the child. So you will have that available to you. Let's do an example. So insulin to carb ratio, let's say in this case, there is 45 grams of carbohydrates for the child's lunch. And the insulin to carb ratio is 15. So what do? You take the 45 divided by 15, you would get 3 units of Humalog. You see here in bold, I have written, do not give this injection until the blood glucose has been checked. You hold off to that number, the 3 units of Humalog. Now let's discuss the correction factor. And again, it is 1 unit of rapid acting insulin, bringing down the glucose by whatever certain points that we have noted on your school order when the blood glucose is above a certain target that we have stated for you. For example, if the sensitivity factor is 50, it would be noted as, in certain circumstances, you will see 1:50 greater than 120 milligram per deciliter, the sensitivity factor being 50 and the target being 120. Let's do an example here. So target is 120 for the correction calculation. Your rapid acting insulin, let's say in this case it's Humalog or Lispro. Doctor has prescribed a correction factor of 20, target of 120, so 1 to 20 over 120. Let's say your student's glucose level is 200. And so you take the 200 minus the target, in this case is 120. So 200 minus 120, you divide it by the correction factor. In this case, it's 20. It will give you 4 units of, the calculation is 4 units of rapid acting insulin, in this case, Humalog. Again, I say do not give this injection, hold off, and the student wants to eat. So what do? Add the 3 units you got from the grams of carbs to the 4 units for the correction. You get the total dose. The total dose in this case is 7 units of rapid acting insulin. Inject 7 units of that rapid acting insulin before your student eats the meal or the snack, unless specified in the school order what the physician has preferred for that student. Now, rounding the total insulin dose. One thing that I would like to tell you, not all these numbers are going to turn out to be a perfect number without decimals. But when you do get decimals for the carbs, when you get decimals for the correction, do not round them off initially. Just keep that decimal. You add up the number, the whole number and the decimal. You add the carb units to the correction units. Then if you, let's say you have a certain decimal, this guides you for rounding. If its decimal is 0.0 to 0.2, you round down to the whole number. In case that a student has the capability of having a syringe that provides half unit or an insulin pen that provides half unit, then when you have, let's say, your decimal of 0.3 to 0.7, you can round it to the middle, which would be the 0.5. So in the example, if it's 1.6, it becomes 1.5. Only in a case where the syringe or the pen has half unit capability. And if it's 0.8 to 0.9, you round up to the higher whole number. In this case, if it's 1.8, you will round it up to 2. I might have gone too fast in this calculation for the insulin to carb and the correction and the total dose, but bear with me. These slides will be made available to you, and you can always call us as well when you're in school with your student, and we will clarify the information for you. And we can send you actually forms to help you guide you through that calculation. Blood glucose range in our endocrinology clinic for children less than 5 years of age, we like the blood glucose range of 70 to 150 with a target of 150. Children 5 to 11 years of age, blood glucose or blood sugar range of 70 to 150 and target of 120 milligram per deciliter. Children 12 and older, we have the range of 70 to 140 with a target of 120. So blood glucose range for the children and adolescents, according to the American Diabetes Association guidelines 2019, in type 1 diabetes, before meals, 90 to 130 milligram per deciliter would be the recommended range. Targets are individualized. And in cases where you have a student who have frequent hypoglycemia, low blood sugar, this might be different. Or in a child who has hypoglycemia unawareness, that is something that we're very much aware of, that if a child has that unawareness, meaning they do not exhibit the signs or symptoms of low blood sugar, meaning breaking out in a cold sweat, getting jittery, potentially forgetting their words, getting really hungry, and just not feeling well, wanting to lay down, feeling fatigued. In this case, the before meal or the range might be different. So the caveat is always there, also by the American Diabetes Association. In children with type 2 diabetes, the glycemic targets will be individualized. What is considered hypoglycemia? It's basically blood glucose of less than 70 milligram per deciliter. And hyperglycemia, high blood sugar, is considered as blood sugar greater than 250. The insulins. So you will get the vials of insulin for certain children. Let's say your student has a pump. I hope that the parents have provided you a vial of the rapid acting insulin that you have kept, let's say, in the refrigerator. And you might have, let's say, just the child is just using the vial and syringes, and you do have the disposable syringes, of course, provided by the parents. And I have provided you a website that you can later refer to when you get the slides, and it will help you let's say in the administrative office, if a school does not have nurses, health aides, or health assistants, they may like to review this, how to draw the insulin. And the pumps, insulin pumps, have their own syringes. I hope that the family has provided you with that particular syringe and needle, and they will have reservoirs and cartridges or cartridges that have been provided to you in case you need to actually take action during the time that the student is with you. You will use the vial, you will use the syringe and the needle with that pump, and you will follow through with what is needed, and Callie will speak to that. I have provided you a fantastic access to a website, and it's on-demand site for school nurse webinar. This pertains to one of the pumps, which is the Medtronic. I had access to this one. If you go on that website, you will see many, many different webinars that you can actually watch and learn more about diabetes and pumps, particularly the Medtronic. But there is particular one that is for school nurses, and you will find that so helpful if your student is on the Medtronic 770G pump. You will find that that would be very helpful for you to understand the parts of the pump, the characteristics of the pump, how to maneuver through the pump. It will show that to you. The child may come to you with pens, pre-filled pens that have built-in cartridge or a reusable insulin pen, where you have just the cartridge provided to you by the parents that you would have extra, but that pen would be good still for 28 days after the start. And remember that the pens need priming. I have provided you a website from the YouTube that you can watch a video to see how to prime a pen. So you turn the dial from 0 to 2, hold it upright, push the button, and it squirts out the 2 units of insulin to just prime it. Or it's the same as the syringe when you just tap the syringe to get rid of the bubbles. It's the same thing. So every time before giving the dose to the child, if they have a pen, you will go ahead and prime the pen and then turn the dial to the dose that is needed for the student. And you will provide that insulin injection for your student. The expiration date on the bottle is different than when that vial or the pen is going to expire, because it does expire 28 days after the start of the start use. Supplies at school, we always remind the families to provide the school with the insulin, syringes, pen needles, pens, pump supplies, all of that for you. Glucagon, alcohol wipes, ketone strips, all of those are very much needed. And again, you do not need to refrigerate the child's insulin pen or vial. Once it is in use, it is good for 28 days, and it does not have to be refrigerated, nor should it be in a temperature higher than 86 degrees. Sharps disposal, again, I don't want to preach to the choir. You guys are pros at this. However, for the lancing devices, syringes, pen needles, insulin infusion sets, continuous glucose monitor sensors, they all need to go into the sharps disposal, which is a heavy plastic or metal container. Website is provided to you to see the guidelines per state and what to do as far as their sharps disposal and how to dispose of them. Sharps disposal, what to do, make sure that it's not a transparent container. It should be puncture proof. We all sometimes provide our students with the laundry detergents or bleach bottles to use at home. It should be, the lid should be tight fitting. A heavy duty tape will be taping the lid, and then you want it to be 3/4 filled, not full, and keep that away from other students. Of course, at school, we tell the families to keep it away from pets and their other children. And you dispose of the taped container in the main garbage can. You can do that. And again, you can look up the website that I have given you for different states. Do not have your container placed in a recyclable container, and don't throw loose needles into the trash. Trust me, I am really not really reminding you guys of that. You know what to do. But the students, you believe it, I'm sure. The kids go to the bathrooms, they check the sugar in the bathroom, they give their insulin, like in high schools, for example, they give themselves insulin, they might throw their syringes or pen needles or strips or lancets into the garbage can. You don't know how many times we remind the kids not to do that. So please remind the students as well, and always capping the needles. Always do not overfill the container that's for the sharps disposal. Use a glass, do not use a glass container or a transparent one. I know that I went through the calculations quite rapidly, but know that you can always reach out to us, and we're always open to your questions. Do type in through the chat your questions. We can respond. And also, again, after our seminar is over today, we will be able to receive your unanswered questions through our communications department, and just rest assured that we will respond to those. I hope that this was helpful to you, and I look forward to hearing you on the phone. Thank you so much, and have a phenomenal day. Thank you, and Nancy will be after me in 5 minutes. Thank you. Bye-bye.
morning, everybody. My name is Nancy Kuzman. I'm a nurse and a certified diabetes educator. I'm also a parent of a now 30-year-old daughter with type 1 diabetes who was diagnosed when she was 8 years old. And that's when my diabetes education career began. I want to thank all of you who educate themselves to safely care for these children who need help in the school setting. So I appreciate you all being here. Today I'm going to talk about highs and lows at school and emergency treatment. It's really important to be well versed in these types of situations because you want to avoid any progression to very scary situations. We know that when children have very low blood sugars, they can suffer consequences like hypoglycemic seizures, and on the other side of the coin, when their blood sugars are very high, we see instances such as diabetic ketoacidosis and hospitalization, which are also very scary situations. Our objectives today are to review the actions to take with a student experiencing hypoglycemia or hyperglycemia, to identify how ketones affect the body and how to treat ketones in complex situations, to verbalize an understanding of the rule of 15 and provide example of treatment options to treat low blood sugars, to identify how to use all forms of glucagon to treat severe hypoglycemia, and to prepare for special situations such as lockdowns, and we'll talk about some of those later in the presentation. We really just want to explore and apply problem-solving skills when working with children with diabetes. We're first going to talk about hyperglycemia. Hyper, the word means high, and glycemia pertains to blood glucose or blood sugar. We're going to define that as over 250 milligrams per deciliter, and it's usually defined in the doctor's orders, or you might also see this acronym DMMP, which stands for the Diabetes Medical Management Plan. It's the same as the school orders or the care plan. We're going to use those terms interchangeably. Symptoms of a high blood sugar usually include drinking a lot, peeing a lot. It can be, the child can experience fatigue, blurry vision, headache, irritability, nausea, and inability to concentrate. The condition can progress to more severe symptoms, including vomiting, respiratory difficulty, and may result in a condition we call diabetic ketoacidosis. Causes of high blood sugar can include late, missed, or too little insulin, expired or improperly stored insulin, illness or injury, stress, hormones, other medication, or any combination of these. I just want to point out that it's not important to determine the cause of hyperglycemia at the moment. We really just want to treat it. But we want to determine in the future if there's a need for adjustments in the treatment plan based on any trends or patterns that we see. So treatment for hyperglycemia is, it's not a bad idea to verify a blood glucose with a finger stick. In today's diabetes world treatment, we see a lot of continuous glucose monitors worn by children, things like Dexcom, the Freestyle Libre, or the Medtronic sensor. So we get very used to using those sensor glucose readings. Again, not a bad idea to check with a finger stick because we know that continuous glucose monitors can be most inaccurate when the blood sugars are extremely high or extremely low. So I just wanted to point that out. We next want to check the urine or the blood ketones to see if there's ketones in the system. Ketones should be an indication that there's not enough insulin in the system and that we need to administer more insulin to clear the ketones that can be very acidic to the body, and as quickly as possible. We want to allow free use of bathroom and access to water or sugar-free fluids to clear those ketones. And then administer insulin per the care plan instructions. Like Apame had just shown us how to figure out the insulin sensitivity factor or the correction factor. And then some care plans actually allow for an adjustment of dose for moderate or large ketones, and I'll be reviewing that in the next couple slides. We want to restrict exercise, like Juliet mentioned, if the ketones are moderate or large and the blood sugar is over 250. We want to recheck the blood glucose every 2 to 3 hours and correct if necessary. We know that the rapid acting insulin, the duration of effectiveness is about 2 to 3 hours, so it's acceptable to correct blood sugars every 2 to 3 hours. And then we want to note any patterns, communicate with the parent or guardian. I know that a lot of you have good relationships with the parents and know what their preference is about communicating these types of things, and it's important to let them know so that they can determine if some adjustments need to be made. I'm going to talk a little bit about ketones without hyperglycemia, and we can see this occur in children when they're ill or if they're limiting carbohydrates, a condition that we call starvation ketosis. So it's possible to have normal blood sugar levels with ketones present. That's why we always suggest testing for ketones if the child is ill. If they're using urine ketones, all it requires is getting some urine on the color or on the chemically treated strip, and then comparing that ketone strip to the color chart on the bottle. On the directions on the bottle, it will tell you very specifically how long to wait before comparing the color chart, and it will you also have to be cognizant that when opening a bottle of ketone strips, they normally expire after about 6 months, and that will be right on the bottle. You can read that. Regardless if the blood sugar is normal and there's ketones, we want to give some carbohydrates to bring the blood sugar up so that we can correct the blood sugar and give some insulin. Again, I mentioned it can be tricky, especially if the child is nauseous. So we want to give small sips of regular soda or a sugary beverage every 5 to 10 minutes until the blood sugar is high enough to give a correction. And good options for this might be Gatorade or ginger ale or 7-Up or juice, anything that the child can tolerate. And then the adjusted dose that we use at our clinic for moderate or large ketones is we take the blood sugar minus the target, which is usually 120, and we divide that by the insulin sensitivity factor or the correction. For moderate ketones, we multiply that by 1.1, and that's the adjusted insulin dose. For large ketones, we multiply by 1.2. And very simply put, that's just adjusting it 10% more for moderate ketones, 20% more for large ketones. That helps the body rid itself of those excess ketones. On the other end of the spectrum, we have hypoglycemia or low blood sugar. The word hypo means low, and again, glycemia pertaining to glucose or blood sugar. And the standard definition of that is less than 70 milligrams per deciliter. There are certain levels of hypoglycemia. The ADA defines level 1 as less than 70. Level 2 is a blood glucose of less than 54 milligrams per deciliter. And level 3 is severe, needing assistance. Regardless, the symptoms may include feeling shaky, weak, pale, sweaty, dizzy, tired, having a headache, or being extremely hungry or confused. Usually a child can verbalize that they don't feel well, that they feel low. They may have certain words that they use. My legs feel weak or shaky. You'll get to know those children's symptoms and what they are experiencing. The condition can progress to more severe symptoms, including loss of consciousness, seizure, and death. So it's imperative that we work quickly to prevent progression of symptoms. The causes can include too much insulin for the amount of food that we're eating, too little food or delayed meal or snack, extra or unplanned physical activity, illness, medications, stress, or again, any combination of these. And like I said, with high blood sugar, it's not important that we really determine the cause of it in the moment. We just want to treat it quickly, but we want to reflect back and determine what happened, and so that we can perhaps prevent it in the future. So the treatment for hypoglycemia is, again, we want to verify with a blood glucose finger stick. It's never a bad idea to do that, just to confirm the sensor glucose if they're wearing a continuous glucose monitor. If we're unable to test with a meter, we always want to treat it as a low. When in doubt, treat it as a low blood sugar. Never ever send a child with a suspected low blood glucose anywhere alone. That can have disastrous effects. And we want to follow the rule of 15. We want to treat with 15 grams of fast-acting carbohydrates. And we'll talk about what options to use. Retest the blood glucose 15 minutes after treatment. Repeat the treatment if the blood glucose remains less than 70 milligrams per deciliter, and then follow with a carbohydrate plus protein plus fat snack or meal. I just want to point out that students on integrated pump or CGM systems, such as the Medtronic 670 or 770G system, or the Tandem T-Slim with the Dexcom integrated system, you may not have to use 15 grams of carb to treat a low blood sugar, because these systems are better at preventing extreme lows, and they're already cutting back on the amount of insulin. So the kids aren't getting as low. So we're finding more like 8 to 10 grams of carb is usually sufficient. And then I also want to reiterate that after the initial treatment with the fast-acting carb, the more complex carb with some protein and fat actually helps hold the blood sugar at a safe level. We know that when we have a hypoglycemic episode, that it depletes the sugar stores that are in the liver, and that the child will be more prone to subsequent episodes. So these are just some examples of some 15-gram carbohydrate options. One of the easiest things to use is 4 ounces of fruit juice. The small juice boxes usually fit that bill. It's unimportant whether it's orange juice or apple juice or fruit punch. Usually all of them are around 15 grams of carbohydrate. They go down pretty quickly. 3 to 4 glucose tabs are also an option. Each glucose tab is 4 grams of carb each. The downside of using glucose tabs is sometimes it takes young children a long time to chew these up. 4 grams or 4 tablets can take them forever to eat. So the Good thing about glucose tabs is the body doesn't have to convert it into anything to use it immediately, and it's handy to carry. A tube of glucose gel can be used, or a small tube of cake gel that can be actually absorbed in the buccal cavity, which is in the cheek. So the child doesn't even have to chew or swallow or anything. It already starts getting absorbed. Hard candies such as 4 to 6 Lifesavers, 10 to 15 Skittles, 6 to 8 Sweet Tarts also works. 2 to 3 teaspoons of honey is an option, or about a half a can of regular soda. We don't want to give diet soda, remember. And then just of note, please never use chocolate to treat a low blood sugar. It has too much fat in it, and it takes a long time to metabolize. And although everyone wants to use chocolate to treat a low blood sugar, it's not a good option. Severe hypoglycemia is the inability to eat or drink. The child becomes unconscious, can become unresponsive, and seizures and convulsion can occur. The treatment is always administration of glucagon and notification of 911. This is what we would call a level 3 where we need assistance. And it's imperative to act decisively and quickly in a situation like this. Severe hypoglycemia is rare but life-threatening if not treated promptly. So the first thing you want to do is you want to keep a level head. Unfortunately, from personal past experience, when I've been involved in situations like this, it's always a stressful and chaotic environment. So you want to try to delegate responsibility to clear the room, contact parents, 911, get some help. You want to place the child on their side on the ground or a stable surface. And the reason we want them on their side is that when we administer glucagon, the act of the blood sugar rising quickly can cause nausea and vomiting, and we don't want a child to aspirate that. We want to keep the airway open by lifting the chin, and then prepare and inject the glucagon or administer intranasal glucagon. Never put anything in a child's mouth when they're unconscious. Call 911, contact the parent and guardian, and stay with the child until help arrives. We have many glucagon options now. It used to be we only had the original Glucagon Emergency Kit made by Lilly. You might be familiar with that. That's the red kit. Or the Glucagon Hypo Kit made by Novo Nordisk. That's an orange kit. We now have Baqsimi, which is a nasal glucagon made by Lilly. We have Gvoke Hypo Pen and prefilled syringe made by a company named Xeris. And the newest is a formulation from called Zegalog or Zegalog. It's a prefilled syringe and auto-injector made by Zealand Pharma. Glucagon is a life-saving hormone that raises blood glucose level by stimulating the liver to release stored glucose. It's a treatment for severe hypoglycemia that cannot harm an individual, so put your mind at ease about that. It's administered by anyone, although an individual may need to be trained, especially to prepare the original injectable kits. It's stored at room temperature. It should be kept at a convenient location. I just did learn yesterday from the Zegalog representative that when it is stored in the refrigerator, it's got a 3-year shelf life. So that's the one exception to the rule. The expiration date must be monitored. It's usually a 1 to 2 year shelf life. And after mixing, you want to dispose of any unused product. I encourage you to consult YouTube videos or the manufacturer websites for videos on how to use the preparations and to refresh your knowledge of this on a regular basis, since it's not something that we use every day or even once a year, hopefully, just to refresh your knowledge about that. Lilly has a Glucagon app with a tutorial and practice injection steps if that's helpful to you too. So these are the two original Glucagon kits that I spoke about. Lilly, the red one on the left, and the Novo Nordisk in the, on the right in the orange kit. It has two parts to it. The diluent is in the syringe, that's the liquid portion, and the medication is a powder form that's in the vial. So the first thing you want to do is flip the cap off the vial. You're going to remove the syringe cap and inject the liquid into the vial. You're going to gently roll the solution until it's clear. You want to avoid shaking the vial. We don't want any bubbles or a lot of bubbles in the formulation. Going to drop the entire contents, which is 1 milligram, and administer that for a child weighing greater than 44 pounds. And it's a 0.5 milligram or half of that entire dosage for a child weighing less than 44 pounds. It can be injected either subcutaneously or intramuscularly in the arm, leg, or buttock. And the needle is large enough that it can be injected through clothes if necessary. The next formulation is Baqsimi. This is the nasal glucagon made by Lilly as well. It was approved in August 2019. There's no training really required for this. It's approved for children 4 years and older. The dose is 3 milligrams. It's only one dose, and it's administered by pushing the drum up on the formulation. It's kept in a shrink wrap tube. It should be kept in that shrink wrap tube until it's ready for use. So you can see the longer white portion of that is actually put in the nostril or nair of the child, and you want to try to get it well in place. And then at the bottom is a round drum with a green line around it, and you just push that in and it dispenses the medication, and it's absorbed by the nasal tissue, and it is activated right away. Again, ease of use, sometimes some trouble getting it covered by insurance, and we've had some reports of some burning or nasal discomfort after use with this. This is the Gvoke product made by Xeris. It's available in two forms, the pre-filled syringe and the Gvoke Hypo Pen. On the left, the pre-filled syringe is just nothing more than the diluent and powder is already mixed, and it's in a injection form, kind of like a insulin injection. It's a shorter needle, like an insulin needle, ready to use. It can be injected. It's a sub-Q injection in the arm, thigh, or abdomen. The Gvoke comes in two different preparations, 0.5 milligrams for 2 to 12-year-olds weighing less than 100 pounds, and 1 milligram for ages 12 and above weighing 100 pounds or more. On the right is the Hypo Pen. It's used much like an EpiPen. You remove the red cap to it, and there's a yellow end. The yellow end is placed in the arm or thigh or abdomen, and then you just press on the pen. No needle is ever seen. There's a little dose indicator window that will show that it's been dispensed, and a little red bar will show in that clear window to show that it's been used. And then the newest formulation is Zegalog or Zegalog. Again, it's got the two preparations like we saw with the last one. This is a stable liquid glucagon analog. They've modified it to act a little bit quicker and to be a little bit more stable than some of the other formulations. It was just approved in April of 2021 for ages 6 years or older. The dose for adults and children is 0.6 milligrams. Again, it comes in that pre-filled syringe and auto injector, and it's a sub-Q injection in the abdomen, the buttock, the thigh, or the outer upper arm. And as I mentioned before, when refrigerated, a 3-year shelf life, and at room temperature, a 1-year shelf life. Special situations. Unfortunately, we must be prepared for extraordinary circumstances in today's world. If school goes on lockdown, we encourage you to have to-go kits, which would include 72 hours worth of diabetes supplies with essentials, and determine who is responsible to carry that with the student. Other atypical days may include field trips, overnight trips, competitions where they're away from school. Try to plan and prepare with the student and parent if meals or snacks are going to be different, if there's going to be extra activity, or if insulin adjustments are going to be needed. With these integrated pump and CGM systems, they're often able to handle changes in schedules, so that's not as necessary, but the children that are on injections may need to make adjustments. And then I don't even know if these are still going on in school, but celebrations, if there's any kind of food being given out at school, it's just important that the student know the carb count of the food so that they can dose the appropriate amount for the carbohydrates that they're eating. And my last slide is just some emergency treatment list of supplies. I would say this is the bare minimum. You would want a glucose monitor, test strips, lancet, some fast-acting carbs, snack, unexpired glucagon and ketone strips, some sugar-free fluids. Obviously, if you have time to have some insulin on hand and syringe, those would be things that you would want to include in your emergency treatment kit. And with that, hopefully all your questions were answered while I was presenting, but we're happy to help you at any time. Just contact the clinic. We are your partners. And again, thank you again for helping the students.
Hi, welcome back everybody. My name is Callie Siderwitz and I am a registered dietitian and certified diabetes care and education specialist here at TMCOne Pediatric Endocrine. I always share that I myself live with type 1 diabetes and I wear an insulin pump and a continuous glucose monitor. And so I also wanted just to thank all the school nurses out there because I was one of those kids in the school that needed help from school staff managing my diabetes. So with that being said, we are going to start this presentation, troubleshooting diabetes devices while in school. So just a couple of the objectives. Today, we're going to briefly identify pumps and continuous glucose monitors, which I will be referring to as CGMs. Discuss some common misconceptions around insulin pumps and continuous glucose monitors. We will review supplies specifically for pumps and CGMs. Discuss what to do if technology fails. Discuss advancements in technology specifically for pumps and continuous glucose monitors. And then discuss some common issues and go through a scenario or two that arise during school with insulin pumps or continuous glucose monitors. Just a disclaimer, diabetes care and education specialists cannot provide patient information or make medical recommendations. This presentation contains general insulin pump and CGM information that is meant to help facilitate the understanding of how these devices work. Pump and CGM companies each have their own certified trainers that provide education to their individual products. So with that being said, during this presentation, I'm going to just give generalized pump and continuous glucose information. I'm not going to be selling any products or anything like that, just general information. So an insulin pump is a small electronic device that simulates the way the human pancreas functions by delivering a small dose of rapid-acting insulin continuously. And this is referred to as a basal rate. Most of school personnel shouldn't have to do anything with the basal rate. This is something that is continuously being administered at all times. The only reason you might have to mess with this in the school function or school setting is if maybe a person's blood sugar is dropping and you want to stop that continuous flow of insulin, but typically this is something that just kind of goes in the background. Insulin pumps also are used to deliver variable amounts of insulin to correct high blood sugars and to deliver for snacks and meals. And this is referred to as a bolus when you give a bolus on a pump. And this feature you are probably more familiar with because every time a child eats something or has a high blood sugar, you would be helping them give a bolus to correct a blood sugar or cover a meal. I'm going to go back really quick. These are the 3 pumps that are available on the market. You've got the Medtronic, the Tandem, and the Omnipod. And I do have 2 different pictures of Omnipod up there, and that's just because there's a little bit newer version and a little bit older version. So maybe you've got kids on either or in your school. Continuous glucose monitors are medical devices that continuously monitor blood glucose levels in real time. You see on the slide here that you've got the Medtronic, the Dexcom, and the Freestyle Libre. I'm just going to explain how a continuous glucose monitor works. So with all CGMs, there is a tiny wire that is under the skin that is measuring interstitial blood glucose levels that then relay data to a device that shows what blood sugar is either every minute or every 5 minutes. What's really nice about these devices are that they have trend arrows. So you're able to see where the blood sugar is being predicted to be in the next 30 minutes to an hour. There's also alarms. So depending on where the healthcare provider or the parent has set the alarm threshold, It will alert you when the child's blood sugar is predicted to be low or high. And something I just want to make clear is, and Nancy talked about this a little bit, is that continuous glucose monitors aren't measuring the same if you were to test a blood sugar with a finger stick, because it's using that interstitial glucose or that fluid between the cells. Therefore, it could possibly be lacking. So if you have a child who's got a straight arrow up or a straight arrow down, and you were to do a finger stick, you might notice a pretty large discrepancy between what the continuous glucose monitor is showing versus what the actual finger stick is. And so just be aware of these things when it comes to continuous glucose monitors. And with both pumps and continuous glucose monitors, I underlined the word device, because even though these devices are wonderful and they make managing diabetes much simpler, like a cell phone, devices can fail. And if that were to happen, Apame talked about those school orders. You might have to give a manual injection or do a manual finger stick, because if a device fails, we have to go back to doing those types of things. Common misconceptions. If a CGM is worn, then it needs to be calibrated. This is false. So as continuous glucose monitors have continued to get better and better, the FDA says that not all of them have to be calibrated anymore. And as time goes on, I'm sure all continuous glucose monitors, might do away with calibration. And so years ago, they did have to be calibrated, but as time has gone on, they might not have to be anymore. I should watch CGM trend arrows all day and react to every change. This one is definitely false. Keep in mind, again, that trend arrows are just predictions. And so we've had, a school nurse call because a child's blood sugar was 68 and double arrows down, and they wanted to know if they were supposed to administer glucagon. And I said, is the child, are they talking? Can they drink juice? And yeah. And I said, okay, well, you can, treat like you normally would. It's just a prediction what that blood sugar is doing. And if a child is awake and responsive, then by all means, give them juice or Skittles or glucose tabs to raise that blood sugar versus having to administer glucagon. Plus, if you sit there and look at trend arrows all day long, you're probably going to drive yourself crazy. So just keep in mind that they're predictions. Children that use their CGM and pumps as receiver should not be looking at their cell phones during school hours. This is also false. So cell phones are now, or can be considered, a medical device. And I know that every school is different, and maybe cell phones, aren't allowed at school, but if a parent has written in the 504 plan that the child can carry their cell phone, we hear from kids all the time that they're constantly getting in trouble from teachers because they're looking at their cell phone. And a lot of times these kids get really embarrassed if alarms are going off all the time. And so they like looking at their phone to see what their blood sugar is doing, because if they're able to correct that blood sugar before that alarm goes off, then maybe it won't be as embarrassing. And so as school staff, educating teachers that, cell phones are a medical device and can be used if it's, written in the 504 plan and everything is understood. Regardless if CGM is worn, I must do a finger stick before I administer insulin. This is also false. You can use a CGM level to administer insulin. However, just like Apame had mentioned, if you ever question what the CGM is telling you. Maybe the blood sugar says 150, but the kid is acting funny and you're thinking that they're actually low, then by all means, please do a finger stick. That's the golden standard of how to test a blood sugar. But I don't want you to think that you can't use the CGM if the signs and symptoms match the number that is showing. Kids with insulin pumps and continuous glucose monitors do not have to have diabetes supplies at school. This one is definitely false, and we're going to talk a little bit more about this one on our next slide here. So guardians should still be supplying insulin to the schools, whether it's in a pen or a vial, the pen needles and syringes to go with that, a blood glucose meter, test strips, lancets, ketone strips, and something to treat a hypoglycemia or a low blood sugar. They may provide for pumps extra tubing, an extra inserter set, maybe an extra reservoir, some extra adhesives. For a continuous glucose monitor, they could provide extra adhesives, extra sensors, and we're going to talk a little bit more specifically about these individual items. But I also want to just make a statement out there that says that every situation is going to be different. And if you're a school nurse or health aide or personnel at the school and you don't feel comfortable, filling up a insulin pump reservoir, again, this is why you would have that insulin for backup, so you could give a manual injection. I'm not saying that schools are responsible for putting a pump side back on, but that might be a conversation that you can have with the guardian. Maybe the child is old enough and they feel comfortable, changing out a pump site if it gets ripped off, or they feel comfortable putting a continuous glucose monitor back on if it's expired. That's a conversation that you can have with the guardian to see, what those steps would be if that were to happen, and if the parent wants them to continue to wear the insulin pump or the continuous glucose monitor in the school setting. But I want everybody to feel comfortable doing so. Some pump supply terminology. So the reservoir is a container that holds the insulin in the pump. And as you can see, I have 3 pictures down there: the Medtronic reservoir, the tandem reservoir, and then the Omnipod. The tubing is the part that brings the insulin from the reservoir to the infusion set. And the infusion set is the site or set that connects the insulin pump to the body. What you might notice is that with the Omnipod, it is the tube, the reservoir, and the infusion set all in one. And so it doesn't have extra tubing or anything like that. Everything is in that little pod there. But we also refer to that pod as the reservoir, as it's the one that holds the insulin. CGM terminology, sensors. This is the piece that is actually measuring the interstitial blood glucose levels. And then the sensor tests the glucose every few minutes, just depending on the type of sensor that you have. Adhesives, these are great. And I do encourage, parents to always give extra adhesive to school staff. They're wipes or overlay patches that can help keep the sensors in place. And so sometimes you may have noticed that on the site, the little edges are coming up and you're worried that maybe it's going to come off. And one of these overlay patches can be placed over it to kind of give it a little bit extra adhesive to keep it on there so that it doesn't come off during school hours. And they make adhesives both for continuous glucose monitors and insulin pumps. In the pictures here, I have a couple of different types of adhesives. There's lots on the market. These are not the only ones out there. And then that's also just showing you specifically what the sensors look like for the 3 continuous glucose monitors that are available on the market. The transmitter is also part of the continuous glucose monitor. It is a small, lightweight piece that fits into the sensor. the transmitter is wirelessly sending data to the receiver or the pump, and the transmitter is commonly referred to as the brain. Transmitters are reused over and over again. Either they're charged or they have a battery life, or they're replaced every 14 days. And so in my slides, a couple slides ago, I had mentioned, what parents may provide to school staff, and I had mentioned sensors and adhesives, but I didn't mention transmitters, and that's just because it's probably not feasible that parents are providing extra transmitters to the school unless they wear the Freestyle Libre, which the sensor and the transmitter is all in one. So just getting you familiar with some of that terminology that is associated with a continuous glucose monitor. Last but not least, you have the receiver. This is a slim, portable component that is carried by the user. So as you can see, there is many different forms of devices that can be used as the receiver. Some of the continuous glucose monitors come with their own receiver. As you can see in the picture there, you've got the Dexcom and the Freestyle Libre. It's a small device that is just used to show data. Kids can also be using their cell phones to see data or their pump. A question that I've been asked in the past about the receiver is a school nurse called and wanted to know why she had 2 kids at school, and one of the children she was able to see the arrows at all times because they were using a cell phone as their receiver, where the other child was using the receiver that came with the CGM, and she wanted to know why she couldn't see that kid's data. And I explained to her that unfortunately, if a child is using the receiver that comes with the device, that isn't able to share data. Only cell phones with Bluetooth capability are able to transmit data to another receiver and share data. Pump malfunctions. Even with modern insulin pumps, errors of insulin infusion can occur, and there's lots of different reasons. Insulin infusion set blockage or an occlusion. An occlusion is defined by basically it blocks the flow of insulin, and sometimes it doesn't mean that the cannula is bent, which I'm going to talk about here in a moment. It could just simply mean that maybe the child's parent changed the infusion set that morning right before school, and it was placed, just perfectly to the point where it was, resting against something, and it was occluded, and it can't get the flow of insulin through it. Sometimes the pump will alert you and tell you that it's occluded, or other times it won't alert you, and this is called a silent occlusion. And so basically we always say, if you've given a correction and it doesn't come down, then it might be smart to change out that infusion set. You can also have bent cannulas, which can happen as well. It basically just means that that little tube has gotten bent, and when it gets bent, obviously insulin can't flow through it like it should, and this would also result in high blood sugars. Dislodged or leaking cannulas. So sometimes when a pump site is worn, maybe the child runs into something or it gets bumped, and that small tube can come out of the skin but still be laying under the adhesive. And so if you ever smell insulin or you can feel it wet right around that infusion set, that's probably because the cannula is dislodged or leaking. And that means, again, that insulin is not flowing to the body, and so we'd have to replace it. Extended use or malabsorption. So all insulin pumps are recommended to be changed every 2 to 3 days. Depending on what pump the child is wearing, it's possible that they're wearing it for a lot longer than 2 to 3 days, and that can lead to malabsorption of that insulin. And so another thing to keep in mind for school personnel is if you see a child and they're always wearing their pump site on the same site, same side of their body, the same right arm, same left arm, it might be having a conversation with the parent to say, hey, I've noticed that little Jimmy is always wearing his pump site on the right side of his arm. That's might lead to malabsorption. Any place that insulin is injected, a pump site can be worn. So backs of the arms, the thighs, the abdomen, and then the lower back / upper buttocks area are all amazing places that pump site can be worn. You can also have user errors. Maybe, again, a parent was in a rush to get to work and they were changing out a pump site, and maybe they forgot to do the last step, or maybe they forgot to fill the tube with insulin or prime the tube, or forgot to initiate the new pump site. This is very common as well, or it could be a combination of these issues. I know that Nancy had talked about what to do for sick day management if a child is wearing an insulin pump, and especially if they have ketones present, large or moderate, we would recommend that you give a manual injection. And that's one of the reasons why, again, we suggest making sure that you have a vial or a pen at school at all times, so that if you would have to give a manual injection, you could do so. This is just another copy of our school orders. I know Apame had pointed out those school orders. Every time, if it's one of our kids here at the clinic, we will be sending you school orders that show what to do about the carb ratio or the correction factor. Therefore, you would be able to calculate that bolus manually and give it manually. Lost connections is another common complaint we get from school personnel and parents too. So just a couple things about CGMs. So keep Bluetooth pairings in your phone or device to a minimum. So if a person is using a continuous glucose monitor and they're using their cell phone as the receiver, if they're also pairing their device with Bluetooth headphones or the car, or lots of things that kids can pair things with, that can mess with that signal and might give you a signal lost message. CGM apps should never be closed. I want to make sure that you understand that I don't mean that you have to keep it up running on the screen at all times. You can minimize it, but you should never exit out of it, because if you exit out of it, it will lose connection as well. Another thing is keeping that cell phone charged. A lot of phones, if you go lower than 10 to 20%, just to go in power saving mode, it turns Bluetooth off. And if you've turned Bluetooth off, then again, you will lose signal or that data connection. And so another common occurrence with children is if they have a lot of games on their cell phone, this can also interfere with that connection. So, as a school staff member, you're not able to tell kids, hey, you got to delete all those games on your phone. But you can maybe have a conversation with the parent that says, we're getting a lot of connection lost at school. I know that if a child has a lot of games on their phone, it can interfere with that. Maybe that's something that you can look into, because we want to help your child and we don't want to have to poke their finger all the time. So we'd really like to see that data. Advancements in technology. As technology improves, insulin pump and CGMs continue to get better and more advanced. Some insulin pumps do have the ability to communicate with continuous glucose monitors. and adjust insulin delivery. This term is referred to as a hybrid closed loop system, or HCL. Both the continuous glucose monitor and the pump must be worn in order for this function to operate. But that doesn't mean that a child can't wear just the pump or just the continuous glucose monitor. They can definitely wear them as separate devices, but if the pump has the ability to communicate with the continuous glucose monitor, you would lose that closed loop hybrid system if they were not wearing both devices. Now insulin pumps, again, as they keep getting better, some of the pumps are able to give an automatic correction. Some pumps will adjust the basal rate, and what that means is if the continuous glucose monitor is telling the pump that the blood sugar is predicted to be high, it will give more or increase that basal rate, or it might give a automatic correction to help get that blood sugar back down into target. Or if it's predicting that it might go too low, it will either back off on the amount of insulin that it's giving or turn the insulin off completely. Pumps are not smart enough to know when you're eating. So if a child ever tries to tell you that, oh, I don't have to enter my carbs into my pump, that's not true. You still have to enter all carbs into all of the pumps. None of them are smart enough yet to predict when a child or any person is eating, but hopefully, again, as this technology advances, that might be a feature that is in the near future. Here's a case study. We received a call from a school nurse stating that a child's blood glucose level was 365 per the continuous glucose monitor, and the insulin pump only wanted to give 1.05 units, and she wanted to know why it only wanted to give 1.5 units. Per the TMC orders that we had sent to them, the child's sensitivity factor or correction was 1 unit for every 35 over 120. The nurse said that she confirmed with a finger stick, which is great. Anytime you have a really high number, it's not a bad idea to check with a finger stick to make sure that it's accurate. And in this particular case, it was 367. She did the math, and according to our orders, the pump should have wanted to give 7 units. She said that in the small left corner, she saw that the pump was displaying that 4.65 units were on board. She did state that insulin had been given 2 hours ago, but doesn't understand why the pump only wanted to give 1.505 units now. The RN also stated that ketones were tested and they were negative. In addition, the child had already changed their infusion set, tubing, and reservoir. So I had a conversation with her and discussed the fact that insulin pumps hold an internal memory. All of them do this. And so this particular child was wearing one of those closed loop hybrid pumps. And with this particular closed loop hybrid pump, it accounts for insulin being on board for 5 hours. And so with the pumps stating that there was still 4.65 units on board, that doesn't mean that the pump hadn't given it yet. It had given that 4.65 units, but it meant that the body was still using that 4.65 units. And after 2 hours, there was still that many used by the body. And so what an insulin pump will do is it'll calculate how much insulin it thinks is needed to bring the blood sugar back down to target. And so if she would have overridden the pump and given 7 units instead of the 1.05, it's very possible that the child would have had a low blood sugar because the pump is very good at predicting, what the amount of insulin is needed based on the continuous glucose monitor and what the pump knows about how insulin is working in the body. She said, okay, now that she understood what insulin on board meant, she had another question. She states last week when she was looking at the pump before lunch, she had noticed that the pump said 1.60 units next to the insulin on board. And so she was wondering if the child had been messing with the pump because she knew that she hadn't administered any insulin, and this child was very young. There was a code that was needed in order to interact with the pump, and so she didn't understand, why there was so much insulin on board if she hadn't given the insulin. And so I was explaining to the nurse that with this closed loop hybrid system, this pump was able to give a automatic correction bolus, which means the child was running high before lunch, and the pump sensed that based on what the continuous glucose monitor was telling it, and it went ahead and gave a 1.60 units to the patient or the child to help bring that blood sugar back down. And so she felt a lot more relieved because she was so worried that the child was, giving themselves insulin through the pump, but it was just the pump that was, doing it for her. This next slide is a great resource slide. If you want to, since these are going to be sent to you, these are all the company's own presentations of their individual pumps. And like Apame was stating, the Medtronic one, the one that I've attached here, is specifically for school nurses, and all of them are great explaining, their individual products, as well as the Dexcom and the Libre. So you guys can check those out if you want to know specific details about the individual pumps that exist. If you have any questions, you can feel free to email us, call us, or continue to provide those questions in the chat box, and we will either have been answering them or we'll answer them as we receive them later on. I just have a couple of references here, and as I understand it, thank you again so much for participating in our lecture today. We're going to take another 5-minute break, and then when we come back, we're just going to do a little bit of wrap up to finish this all up. So thank you guys again for attending this lecture. She's also a wildcat.
She's the right.
She's the wrong kind. I have no affiliations with any sports groups.
Oh, yeah, you make rather. Right?
I am, but you know, whatever.
You're a wildcat for life. I don't know if you guys read the Daily Star, but they're really pushing all that stuff on the football team. Like Chuck Cecil's wife did the whole thing and a whole column on like how.
When
they
are we
use
sending the
it.
PDFs? Next week?
It's funny because I think my
Put her papers on.
Hi, everybody. The whole team is here. We thank you so much for having participated. I believe that we had close to 70 registrants today. We are so pleased to have been able to provide the service to all of you, and just know that you are all the bridge between the children and their families and us. So whatever we can do to facilitate. Just a few things before we finalize and close out. One, keep the lookout for the PDFs of the slides that we're going to email to all of you. And we will also email you a survey, and we will really appreciate your response. It will be a very short survey, just asking you a few questions and your thoughts about this conference that we held today for the first time virtually. Also, we are working on a quick reference guide to make available to all of you electronically, as well as we're hoping the hard copy to be here as well in the clinic if you happen to ever want the hard copy for your school. So that look for that as well. It'll come through your email. Also, we have gift cards that we are going to raffle off for the participants, but the person who had the very first question, if you're still there, your name is Tanya Reed. Yeah, come on, everybody. And for sure, you're going to get the gift card sent to you, but the rest of the gift cards that we have will be raffled. So these are a few housekeeping things that I have. Did I forget anything? No, Dr. Patel, would you like to just finalize? Thanks, everybody. And Dr. Patel's going to sit in the hot seat.
Yeah, I just wanted to say thank you for watching, participating, and helping us. It's always great, and it's great to have an extension part of the team. Obviously, you can see what wonderful people we have working here, and if you guys have questions or need to reach us, please feel free to reach out. We're around, and we're happy to help. It's our mission in life to do good things, especially for the kids with diabetes. So, our fax number is 324-0029 if you need anything. And the phone number is also 324-1010 in case you guys need that. But thank you guys for participating, and hopefully next year we'll be doing it in person, and then we can give the gift cards away at the time we see you guys. So, but yes, everyone have a wonderful day, and we will be seeing you guys next year.